I just want to say hello and welcome everybody. We're trying to bring the energy tonight. All right. These ladies have worked a full day getting their practices together and all kind of other black girl magic kind of stuff. I do want to just give a shout out to TheMelaninMD. They're the ones who basically made this possible. Okay. You can follow them on Instagram at TheMelaninMD. One of the things that they're doing is they will launch an app soon. That app will basically connect patients with Black healthcare providers. So something we certainly need around here. So just be mindful of that. Dr. Chambers, Dr. Johnson, Dr. Joy, if you want to take yourselves off of mute and just say hello, Dr. Chambers, we'll start with you. She says she can't take herself off mute. Let's see if I can. Nope, I can't take you off of mute. There you go.
Initiated, I could. Okay. Hey, everyone. I'm Dr. Chambers, board certified OBGYN. Very happy to be here with all of you. So excited for tonight's discussion.
Okay, Dr. Johnson.
Hey everybody, I'm Dr. Jasmine Johnson. I am also a board certified OBGYN getting specialist training in maternal fetal medicine, so high risk pregnancy. So excited to be here.
Hi everybody, I'm Dr. Joy. So happy to be here as well. I am a board certified in chiropractic. I also do physical therapy and I dabble a little bit in, my specialty actually is perinatal health and I dabble a little bit in functional medicine. So I'm excited for this Black Girl Magic. We're gonna be talking about fertility and pregnancy. So yeah.
So look, one of the things that I want to say real quick is y'all know this is technology, right? Yeah, we know that. We can all agree on that. And y'all know just yesterday, Zoom was down, or was it the day before yesterday? Zoom was down for everybody.
Yeah.
So if we can't take ourselves off mute or something goes wrong, hey, it ain't our fault. We just rolling with it. All right. So yeah, we appreciate everybody for joining in here again. And again, TheMelaninMD sponsoring this. This is all about fertility and pregnancy during the pandemic. I have several questions, but I really want to hear from our audience out there. So if you guys have questions specifically that you want to get answered, yeah, I have 9 or 10 questions that I need to go through here tonight, but we can certainly pivot and answer some other ones. So please feel free to put your questions in the comment section. Let us know. Make sure you send those questions to the audience and the panelists so we can all see them here. I'm seeing a lot of folks. Gina, let's see here. Kristen, San Antonio, so many folks in here. Dr. Topaz, did I say that correctly? Yeah. Dr. Chambers. Okay. All right.
Yeah.
All right. Yes. We got plenty of folks in here. So we're going to start these questions. Okay. Number one, what can a couple do to improve their chances of conceiving? Dr. Chambers, I'm going to toss that one out to you up first.
Absolutely. So, I mean, your sperm, your eggs are honestly as healthy as you are. And so optimizing your overall health, that looks like having a healthy diet. Engaging in regular exercise and activity and making sure you're getting all of the nutrients that are necessary. For any woman that's trying to conceive, I highly recommend taking a prenatal vitamin as soon as you start or as soon as you stop taking birth control. Just start taking that little prenatal vitamin. It's not going to hurt a thing, but most of the time we recognize pregnancy a bit later than we'd like to, and the prenatal vitamin is critical to something called organogenesis, or the development of the early stages of the fetus. And so we want to have those prenatal vitamins, all of those nutrients there early on. As it relates to timing of conception, that is often tracking your periods, making sure that you're having intercourse around time of ovulation, which is release of an egg. And that typically occurs around day 14 of your cycle, around that time. So nothing's perfect. So we're talking like having sex pretty regularly, day 10 to day, 20, if you feel so moved. So some people really kind of throw off that timing. I'm like, nah, y'all, it's not like having sex on the period necessarily. It's the ovulation time interval. And if ovulation is irregular, periods are irregular, other issues arise, then seeking medical attention as needed. Those are some of my recommendations, and maybe Dr. Johnson or even Joy may have some additional things to add.
Yeah, no, I completely agree. I would piggyback on that as a plug for maternal fetal medicine, that if you do have pre-existing conditions, before you get pregnant is the best time to see a doctor like me, where we can go through your health history and talk to you about what that may mean for pregnancy, and if there's anything you can do to optimize your health prior to getting pregnant. And then just to piggyback off of what Dr. Chambers said, I saw someone in the chat asking about timing. So when should you go to a fertility specialist, or when is it a problem? And we usually say if you're less than 35 years old, intercourse that, like Dr. Chambers said, is timed with ovulation, regular intercourse for a year, and you haven't gotten pregnant, that's when you should seek help. If you're over 35 years old, 6 months, so it's a shorter time interval. And if you know that you have some ovulation dysfunction or irregular periods, you should seek help sooner.
Dr. Chambers, I did just want to say, what did you say was regular sexual intercourse again? So
Now,
it might be some, I'm just saying, it might be some men in here that want some answers too. I don't know. Just
regular is up for interpretation. Okay. And so we let the couple kind of decide that, you know, for comfort purposes. So I'm not going to elaborate, but it's not once during your ovulation window. The more times you have intercourse, the higher your chances are that the little sperm is going to find that egg. So it depends on how badly we want to conceive.
There you go. There you go. You heard what she said. That little sperm got to find that little egg. All right. Okay. We do have a question already coming in. Melissa saying, my husband and I are sexually active, but have never had a pregnancy scare. I'm not on birth control. Should I be concerned? And that question is really just for anybody who wants to jump in and answer it.
And I think Dr. Johnson kind of answered that a little bit. It depends on the timing. That, you know, how old is she? How old is her husband? How long have they been doing it? If it's longer than a year and we've never had any type of pregnancy scare, and we really are typically referencing more intentional intercourse and less of a absence of contraception, for lack of a better term, but longer than a year, like Dr. Johnson said.
One last thing before I move on, because I want to make sure that I get to these questions because folks took their time out of their day to log in here and chat with us. When trying to become pregnant, are there all natural foods, vitamins, things to avoid in order to improve chances? Anybody want to answer that one?
I think that if you start to research on the internet, there are a lot of products that are marketed to women who are trying to achieve pregnancy. And so I say that caution yourself, because there aren't any vitamins that we know of as OBGYN physicians that we recommend to our patients outside of taking a prenatal vitamin while you're trying to conceive to increase fertility. I think that if you are having issues with fertility, going to a fertility specialist is probably the best thing so that they can start that workup. But as far as we know, there aren't any vitamins that we recommend a standard of care for increased fertility.
Okay.
And I think they hit it on, I'm sorry, Tashar, but I think they hit it on the nail when they're just talking about how you have to be at your healthiest optimally in order for your body to be able to do any of its normal physiological functions without a problem. And when we're looking at specifically fertility, we want to make sure that we are giving our body everything that it needs and not like trash. So we're eating healthy, we're exercising, we're in the sun, we're doing all of those wonderful things. We're decreasing our stress, right? It's a hard time right now because it's COVID, but when we do all of these things, our body is able to do our physiological function. And when we look at, let's look at stress, right? Our body creates our whatever, work stress, lifestyle stress, whatever's going on in your life, our body takes cholesterol and it actually makes something called pregnenolone. And pregnenolone is actually the precursor to DHEA, which is what we make a lot of our hormones that we need for fertility out of. And so when we have pregnenolone and we add stress into that, pregnenolone instead becomes cortisol. And when you have heightened cortisol, your body is actually shutting off those fertility hormones. So when we look at like the biochemistry, you'd be surprised how our everyday lifestyle actually plays into that. So making sure that we are doing everything that we can to be healthy is really important.
All right, Dr. Joy, you better school us with the science behind what's going on. Okay, listen. All right. I done got hot up over here. You gonna turn the air conditioner on up in here. Listen, okay. I want to get back to our original question about conceiving. I'm gonna toss this one to Dr. Johnson. How can a woman tell if she is ovulating, or Dr. Chambers, whoever wants to jump in for this one?
I think the most basic way to tell if you've ovulated is if you have a period. So your body, when you release an egg every month, if it doesn't get fertilized, that's when the lining of the uterus sheds. And that is a sign that you're ovulating. So I think that if you have a history of having regular periods to the day and the interval is pretty regular, then the chances that you're ovulating are very, very high. I don't know, Dr. Chambers, if you have another indicator that you tell your patients.
No, you're totally right. So the regular period thing is really one of the best things. And it's what we use as physicians to determine if you've historically been ovulating. But a lot of folks say, well, then what is a regular period? And so it's important, I believe, to kind of define that. When we get into an adult kind of patient population, we make a lot of assumptions. I tend to work with adolescents, and so I'm starting from scratch. I assume nothing, and so I may over-explain things, so bear with me if you guys think this is kind of elementary. But a regular period is typically occurring in an interval of every 21 to 35 days for adult women. It shouldn't last longer than about 7 or 8 days. And so when you have variation that's greater than about 6 days, as in, oh, I have a cycle every 21 days, and I have a cycle every 36 days, that is actually irregular, as in the pattern or frequency of your periods is not regular. If you're skipping more than 35 days, 2 months, 3 months, that's concerning. And that would suggest that you are not ovulating as frequently. If you're not ovulating as frequently, you're ovulating 4 times a year because you have a period every 3 months, guess who's going to have a harder time getting pregnant? You only have 4 opportunities. And so the infrequency of ovulation certainly, and it makes sense, would decrease your likelihood of success when it comes to pregnancy. And so that's why ovulation is so important. Other things we have are ovulation predictor kits, where you kind of urinate on a little stick and it's looking for something called FSH, which is, LH, which is the larger hormone that kind of peaks to release the egg at time of ovulation. And so that's actually found in the urine. And so it's something that you can see when you actually urinate on a stick. And then some people, they're like, oh my gosh, I'm ovulating. Let me run and go have sex. Yes, that'd be correct. So that's another thing to do. And then basal body temperature, you can kind of track your temperatures to kind of see if there's a peak in your temperature, and that can suggest that you're ovulating. That peak is very kind of finite. And so you have to be really good with tracking your temperature. And there's some apps that can help with that. But those are some of the things that help to track ovulation. We as physicians can check some labs, like a progesterone level, to see if ovulation occurred, but that's a partnering with your physician sort of thing.
All right. Thank you for that, Dr. Chambers. We actually have another question. This one is from Brittany. She says, have you all heard of sperm meets egg plan? If so, do you recommend it for trying to get pregnant? It's basically sex every other day until after ovulation.
You already know I do. I mean, I recommend sex for pregnancy. But as far as the sperm meets egg plan, it doesn't matter which plan you're using per se. As far as like how frequently, you don't want to have sex so much that you're stressed out, it's a whole task, and there's no joy there. Obviously, that's going to push your limits. But sex every other day sounds very reasonable during ovulation to help from a trying to conceive standpoint. Jasmine, I don't know, Dr. Johnson, if you agree.
No, I agree with you. I have not specifically heard of that plan, but as we said earlier, regular intercourse at the time of ovulation is what is going to help you achieve pregnancy. So it sounds like I would be in agreement with this plan.
Okay. All right. Next question here. Could a previous abortion or using contraception affect fertility? And I'm just tossing that one out there. Dr. Joy, Dr. Chambers, Dr. Johnson, whoever wants to take it.
I'm happy to, just because it's in the gynecology link, unless anyone objects. So a previous contraceptive, a lot of people have historical references of contraceptives that have affected fertility. Some of the really poorly formed IUDs previously kind of really had kind of infertility as one of those side effects if it got embedded into the lining enough. And so there's a lot of very valid historical references of medical crimes against women, and then just issues as it relates to fertility and infertility related or presented under the guise of contraception. Mm-hmm. Today's contraception, however, does not meaningfully impact future fertility because it is meant to prevent pregnancy. Yes, it temporarily decreases your fertility, but moving forward, it does not. So a study that looked specifically at birth control pills was one that looked at women who were pill users and women who were never pill users, and looked at how long it took them to get pregnant over the course of the year. And it was about the same. So there was no meaningful difference in women who never had a pill and women who were on pills and stopped because they chose and wanted to get pregnant. And so we don't have good evidence that our birth control pills of today are negatively impacting future fertility. Our IUDs, upon removal, you're immediately fertile. Now, when it comes to implant, that's the same. A vaginal ring, same. A patch, same. All of those things are removed. They're reversible contraception, and that is the whole point, for it to be reversible. When it comes to abortions, and we're talking about different types of abortions, there's medical abortions, and then there are surgical abortions. Medical abortions mean I take medication either orally or per vagina that causes me to contract and kind of basically deliver the pregnancy or have a miscarriage, an induced miscarriage. The surgical ones actually use instrumentation of the uterus or the womb to remove the pregnancy. And so in theory, repeat instrumentation can cause inflammation and scarring that could in turn decrease the potential for future pregnancies. And so the answer to that question is it depends, mostly no, but anything in larger quantities, especially when there's surgical manipulation, scarring, instrumentation, inflammation, infection, those things certainly negatively impact future fertility.
All right. I just want to shout out to the folks that are watching us on Facebook. Dr. Chambers, appreciate you answering that question. We got a lot of folks actually watching over on Facebook. Jennifer saying she's watching from the D. I'm hoping she's talking about Dallas, saying, hey, Dr. Jasmine, we love you. Nice to see everybody represent Black Girl Magic. Maxie is a guy who follows me on Facebook, and he says, hey, have a glass of wine, relax, and get busy. But anyways, we're not going to jump into those, Dr. Chambers. I'm sure you agree with that.
That's just my thing. But.
All right. We do have a question from Kiara. And again, you guys, you can feel free. Anybody can jump in and answer these questions. What are your thoughts on how to manage stress during a pandemic to support fertility?
Ooh, that's a good one. I'll answer that one. So honestly, when it comes to stress management, it's just doing everything that self-care that makes you happy. So exercise, eating healthy. It can be going outside, getting vitamin D. All of those things will reduce the stress in our body, will make us feel good, whether that is getting up in the morning and having a good stretch or going to the swimming pool. So right now it's a little bit hard in the wake of COVID to do some of those things. But if you do have things within your reach that you're able to do, that you enjoy, do them. Those are great ways to manage your stress. If you want, you can actually go, do a Zoom like this with your best friends, have a great call, do some girl talk time. All of those things are included in self-care. Do your nails, give yourself a little foot petty. And when you do that, it just makes you feel good. It releases dopamine and it decreases your stress. So.
All right, good. Did either of you guys want to weigh in on that one? I thought Dr. Joy hit the nail on the head. All good information.
Yeah.
Okay, I want to make sure. Go ahead, Dr. Johnson.
I was just gonna add, turn off the news, turn off the TV, unplug. Unplugging from social media. I think especially right now, we're also inundated with news about everything. And particularly, the Black community, we're being hit in particularly hard than everybody else. And so just unplugging and disconnecting from what's going on also, I think, is a form of self-care. And so, don't minimize that effect either.
Yeah, I'm in the media and look, unplug. Okay. I'm for real. I got to tell myself that. So appreciate you adding in that additional insight in this conversation here. Okay. So we have many questions and I really want to get to some of these. First, we have one from SAAG. Could HPV be a cause for preventing pregnancy?
I can take that one just because that's heavily gynecological. So HPV is human papillomavirus. Human papillomavirus is the main causative agent of changes to the cervix that lead to cancer. And so when we think about cervical cancer, we know HPV is a cause of that. It's also a cause of like genital warts, which doesn't have the same cancer thing, but it's still annoying and an issue. Neither of those necessarily prevent pregnancy. Obviously, if you had advanced disease that necessitated surgical intervention, or, removal of the uterus even, or something like that, then that can impact fertility. But HPV itself is not a cause of infertility, fertility issues, abnormal ovulation, or anything like that. It just doesn't work quite in that way.
Okay. Is there anything we should be thinking about if we're trying to conceive during the pandemic?
Well, Dr. Johnson, you want to take that one?
I would say, the same rules apply. As far as we know, COVID is this new illness. And so we are doing a lot of research right now to see if it affects fertility, if it affects pregnancy, and in what ways. And from what we can see right now in the preliminary data, we don't see a decrease in fertility. We don't see an increased risk of birth defects for pregnancies that are conceived during the COVID pandemic. And so I would say, listen to the CDC and practice their guidelines as far as social distancing and making sure that you're protecting yourself from the illness. But I don't think there are any special precautions that you have to take while trying to get pregnant right now.
And we have a lot of questions. Thank you for that, Dr. Johnson. We have a lot of questions about fertility, specifically in our panel discussion that we came up with beforehand, but we also are getting some in the comment section over here. So one of the questions from Sierra, and then I'll dive into some of the ones we came up with, is what can I do now that I have been diagnosed with unexplained infertility?
Unexplained infertility is more common than we think. You know, we like to be able to pinpoint a cause because that then gives us a plan of action. But when we're kind of in the land of unexplained infertility, that's when I believe it is most important to partner with a really good physician that you trust, because they will then lay out all of your options. We've gotten so good that as long as you have ovaries and you have eggs that can be really kind of extracted or retrieved, you have a possibility of having biological children. That could be with someone carrying that child for you, that pregnancy. We can make embryos outside of the body, taking your egg and sperm. There's so many options that when you get a diagnosis of unexplained infertility, what I believe is the most important step is education. Educating yourself entirely and partnering with the physician, because that's going to be a longer road potentially. Now, there are people who have unexplained infertility that wake up one day and they're pregnant. They're like, oh, how did that happen? We don't know. Okay. But for pregnancy to occur, there are literally millions of things that have to happen exactly right. And so fertility is a very nuanced and complex thing. And so when you get to a land where I can't find a reason for my infertility, I need a specialist. That's what I would say.
I want to jump in here. I know the MelaninMD, when they launch their app, they're going to be able to connect folks to different Black healthcare providers that can help them with different areas of expertise. But I do want to ask you ladies, what's the best way to go about finding a doctor or someone who can help with infertility? How do you, start those conversations and finding the right person for you?
Oh, good question.
Do you want to take that, Dr. Chambers?
Well, I mean, I love the friend approach. I'm down for asking friends. I love a referral, a review. Those, I definitely prioritize those. But typically, it's going to be through your provider, your OBGYN. They're going to be the ones who say, okay, we've talked about this for some time. This is important to you. This is an issue. I'm referring you to this provider. I'm referring you to someone in network, someone who I can reach out to, who I know can help with this problem or this issue or this condition. And that's often the best way to get kind of connected to a fertility specialist.
Okay. How long should a couple keep trying prior to seeking some help? So if they've been trying for a little while, and you guys can, I guess, put a time frame on it if there is one, but how long should a couple keep trying before they reach out to a fertility expert or to a doctor to figure out, okay, what's going on? We're not getting pregnant.
And we kind of said this earlier, for women under 35, a year. If there's no other underlying health conditions that could explain why they're having a problem getting pregnant, then a year of trying with ovulation. And then if women are over 35, 6 months. And so I think the take home message here is to not wait. And I think that if you can get a referral from your OBGYN, that's a great way to get to an infertility specialist, but you also have the power to self-refer. And so if you feel like it's going to take 6 months to get into your OBGYN and then 6 months to get the appointment, and you guys have been trying for a year, it's okay to call the infertility specialist office. And the name for it, which I feel like if you're not an OBGYN and you've never pursued this workup before, it's reproductive endocrinology and infertility is a specialty within OBGYN. And so that's the type of clinic that you're looking for.
Dr. Johnson, now, you're going to have to repeat that one more time. Tell us again, sis.
Reproductive endocrinology and infertility, or REI is what we call it for short.
Okay. Appreciate that. Look, Facebook lit. They got a whole lot of questions. I'm gonna get to y'all in a minute. I appreciate y'all tuning in, man. Y'all are really in tuning and with what we're going talking about here. Look, I'm trying to read their questions. Hope has a question for you, Dr. Joy. She says, how does chiropractic care help throughout pregnancy, and how often should I see a chiropractor during my pregnancy?
That's good.
Great question. Okay, so it helps in so many ways, right? And it's so funny because I didn't realize how great it was until I was pregnant, and I was like, ooh, this is amazing. And really what it's doing when you're pregnant is it's helping to just restore the ligaments, the tendons, the muscles of the pelvis. And so that, and also helping the pelvic floor, which is really essential for pregnancy and then the birthing experience. And so when we're balancing out those muscles, tendons, and ligaments of the pelvis, it helps to create a little bit of space, removes what we call intrauterine constraint and torsion of the uterus. And so that makes it for optimal positioning for baby. It helps baby on top of, I'm a perinatal pain specialist. So a lot of women don't even come to me at that point. They're coming before for like round ligament pain, sciatica, piriformis syndrome, and that type of thing. And it's not like it's this one size fits all. So where every pregnant woman that walks in the door, all of a sudden they're put on this like schedule. It's very individualized for care. So there's no way to say how often you should come, but it just depends on what you have going on. And I want to just say pregnancy doesn't have to be painful. So don't wait or live in pain. If something's going on, go see someone, because that's not normal, right? Pregnancy, you should have a little bit of discomfort. You're growing a human, but pain is a different thing. And so if we're feeling those things, we definitely need to get help and seek help.
All right. Good stuff. Appreciate that. I hope that answered. I promise you I didn't try to do that. I hope that answered your question, though. If you have more, please continue to leave it in the comments. Appreciate that, Dr. Joy. Okay, we have a question from Miss Sams. How can we improve the birthing experience for Black women? Let's dive into that one, because that's been a huge topic of concern as of late, but it's been going on for years. I just feel like folks are finally starting to shed a light on it. So who wants to take this one? How can we improve the birthing experience for Black women?
I'll take that one.
Yeah, that's your alley right there.
Yeah. So I like to start this conversation by saying, first of all, there's nothing wrong with Black women. There's nothing wrong with us that creates these outcomes that we're seeing in the news and in research that we're doing. Race is this social construct that was made to create division. And I think that in science, we have turned it into this biological marker for things, and it is not a biological marker. And so as we have finally shifted gears and talking about race and race as a risk factor, it's not race, it's racism. So I just want to say, Black women, y'all are wonderful. Y'all are not the problem. And so talking about how we can attack this problem, well, just like we said before, we obviously want to be our best selves in pregnancy. And so making sure that we advocate for our health outside of pregnancy is going to help improve outcomes in pregnancy. But also finding a provider that you trust, someone who takes this seriously, that Black maternal health outcomes are they are embarrassing. They are a public health crisis, and they exist. And unfortunately, there are still providers out there that don't think that this is real. And so making sure that your provider is held accountable to the statistics that we see, and that they know that in not acknowledging it, they are being complicit. And so you have the power first to choose your provider. And then secondly, y'all need to vote. There's something called the Mamas Act, and it is a number of bills that are in support of Black maternal health outcomes, and making sure that states have funding to look at why the outcomes are so bad, making sure that there's accountability, making sure that we're tracking these statistics so that we can fix them. And so I'd say for Black women, like, those are the big things. Take care of yourselves. You know, this world is hard on us, and there is a scientifically proven theory called weathering, where just being Black and existing ages you faster than any other race in this country. And so I think knowing that we have to take care of each other and take care of ourselves, but then we also need to make sure that we speak up when we feel like we're not listened to. If we feel like our provider isn't listening to us, you are not contractually obligated to stay with them. You can find another doctor, and that is okay. It is okay to switch doctors in the middle of your pregnancy. It's fine. And vote for policymakers that are going to prioritize us.
And I'd like to add to that. That was beautiful, by the way.
Thank you.
But the doula in me also wants to let everyone know that there are things that you can do and take charge of your own health, right? It's very important that we get educated. And so we have these wonderful childbirth education courses, and I highly recommend them. Get educated, learn, so that you can, if you need to, you can advocate for yourself. But if you're not educated, you can't do that. Also, there are things that we see. There's several studies and we know that having a doula present in the birth and that additional support for the woman, definitely improves her outcomes. And so those are always options that you can do. And when we're thinking of what we need in a birthing environment, specifically when things like a birth plan, where you are able to analyze and have an idea of what you might need in that environment, and then discuss that with your provider so everyone's well aware of what your desires are, what your needs are, and those type of things can significantly improve your outcomes.
What advice do you guys have? And this is just me talking. I'm just asking. What advice for real do you guys have for women to ask those questions? Because a lot of times they're either afraid, they don't know how to phrase the question. What advice do you have from that standpoint? Because I just think it's really important to help individuals set those questions up, because people sometimes just don't know what questions to ask.
I think that's such a good question. There's two ways in which to motivate this. One, you write your questions down and you practice phrasing them before you come in, so that you're not having to think on your feet. And this isn't like, some freestyle thing where you're like, oh, let me just get all the right words. Write them down before you come. I am concerned about this because what can I do about this? Da, da, da. So that, if I go to this visit and all of the talking and dialogue doesn't answer these questions, I'm going to bring these up before I walk out of that door. And then, quite frankly, think about it like this. Act like your life depends on it, because it could. Mm-hmm. That's quite a motivator. If you're trying to figure out, do I need to toe this line? Would I look like an aggressive Black woman today? Would I be difficult? Da, da, da. Act like your life depends on it. I have been called a difficult patient. I don't care. I know that matters. I'm like, literally by a specialist. They're like, do you like being difficult? I'm like, if that means advocating for myself, absolutely. And I was raised that way by my mother. So, it's just like, yes, when you call people out and you are demanding what you're due, it can make a person who knows that they are shortchanging you uncomfortable. For a provider like myself, like Dr. Johnson, like Dr. Joy, if I sense that you feel like I'm not quite meeting your expectations, I'm going to spend more time to meet them. I'm going to see where that issue is, because my goal is your goal. All it will do is highlight that you need a different provider. So ask those questions. It will clarify something. I promise you, it will clarify something. And if at the end of the day you're called difficult, that's fine, because you still be alive.
Okay. Oh, I love it. I love it.
And I also want to say that in COVID right now, there are a lot of restrictions on who can come with you to what appointments. And one of the things that I highly encourage my patients when I'm talking to them about complicated things is there someone you want to get on the phone, put them on FaceTime? So similar to having a doula, having someone else be there during the appointment when there are complicated things happening is sometimes nice, because they may be listening to things that you didn't catch. Yes. And also, if you don't feel comfortable speaking up, going into that appointment and saying, hey, I'm going to want to talk about this. If I don't bring it up, please make sure that we bring this up today. So that's also really helpful.
Love it. I love it. I know, look, this is completely aside from the point, but when I was trying to just get a car, having somebody on the phone, because a lot of times you go into these dealerships, you don't know what's going on. So I had somebody on the phone the entire time trying to talk me through this entire process. So I think, Dr. Johnson, that's the same thing, not the same thing, but of course, having somebody there to guide you. Okay.
It's an advocate.
Yes, exactly. We all need advocates. Speaking of COVID-19, of course, and having people at the hospital with you, how has planning for delivery changed in the wake of COVID-19?
I think that it varies by region and it varies by hospital. So even today, if I told you what our hospital is doing, it may be different from hospitals wherever listeners are. But I think that knowing what your hospital specific rules are before going into your delivery is really important. And so I tell patients, call the front desk of the hospital and ask them how many visitors I can have. Typically right now, you can have one birth support person with you. At least that's how we're doing it on our labor and delivery. And they can be with you on labor and delivery and postpartum, but no children, and you can't switch them out. And so depending on what hospital you're at, it's good to know that ahead of time, especially if you have children at home and you need to plan childcare and that type of thing. But COVID has definitely limited the number of people in the hospital. And recently, doulas have been allowed to come in addition to like a partner or whoever you have coming with you from home, which is really important, because I think that we don't want to compromise other things while trying to protect everyone from COVID-19, but it's very hospital dependent.
Okay, I do want to backtrack and go to one of our questions that I actually skipped over. What are the safest and recommended options for childbirth?
Well, Oh, you were going to say something. You can start.
So I'm trying to think of the best way to verbalize this. Ultimately, as a OBGYN who is medically trained and is a diplomat of the American Board of Obstetricians and Gynecologists,
Yes.
a hospital birth is preferable. And we say that because when things go poorly, when things change quickly, your distance from an operating room, from a blood bank, from a NICU, from an ICU, those things, those distances, that amount of time, that is directly correlated to your likelihood of surviving. Okay, to your baby's likelihood of surviving, primarily, really the baby. And so, you know, a lot of folks have kind of made an assumption that it is possibly better to deliver at home during these times because there's so much COVID. You know, we got to stay at home for everything else. School's at home. Should we deliver at home? And I want people to address that very cautiously, especially as it relates to Black women. Okay. And I recognize that the majority of maternal deaths that we've been talking about that are publicized in the news, those occur in hospitals, absolutely. But I can think about so many patients that were transferred to my hospital in residency that would have died if they did not make it in just in time. And so there are more lives saved at the hospital, more lives lost at the hospital, there's more action at the hospital. And so that doesn't quite negate the relevance of delivering in a hospital setting where resources are plentiful. I recognize that it is a mother's right to choose, and that is absolutely appropriate to choose where you're going to deliver. But you really must educate yourself on what that looks like and what that looks like for your baby and how maybe we're limiting options. When things go perfectly, it is beautiful and amazing. But I am trained, Dr. Johnson is trained for when it doesn't go perfectly.
Mm-hmm. That was perfect.
Go ahead.
I was just going to add that who attends your birth is also very important because there are a lot of different titles for birth attendants. And so, you know, there are physicians and midwives and family medicine physicians deliver babies. And so making sure that the person who attends your birth is certified, because there are different types of midwives. There are lay midwives and midwives who went to school for that. And so just making sure that your birth attendant is licensed. And if you are choosing to give birth outside of the hospital, that there is a plan, like Dr. Chambers said, to get you to the hospital very quickly if there is an emergency. And if there is not a plan in place, I beg of you to question why there isn't one. And if there is a relationship with the hospital there, because I think that's when patients get into trouble, when they kind of go outside of the standard systems. And then if an emergency happens, it can be catastrophic.
So, hi, everybody. Respectfully, I disagree. So home birth mama of 2 here. I've had 2 home births myself. I think home births are beautiful. I would like to add, you know, a couple of caveats. I think what Dr. Chambers and Dr. Johnson said, they spoke with facts. They're very knowledgeable. They are trained obstetricians and gynecologists. And it is very important that you do have a plan and that you know exactly what you're going to do regardless of where you're birthing. And you make sure, like Dr. Johnson said, you want to make sure whoever is attending your birth that they're licensed, right? There are several different types of midwives. We have CPMs, which are certified practicing midwives. We have lay midwives, and we have certified nurse midwives, which are kind of like the highest tier of midwives. And so it's really important that we have whoever is attending the birth, make sure that they're certified. When we look at and what the studies have shown when it comes to low risk women and planned home births, there is no increased risk. There is no differences in the numbers that we see at planned home births and what we see at the hospital. Are there always going to be outliers in situations that occur? Yes, that always can happen. But that can also happen in the hospital, and that can also happen at home. And it's important to remember that. There was actually a really good study recently in Canada where they studied about 17,000 women. They looked at the cases of home births, and they found that home births with low risk women with certified nurse midwives present that were planned, right? Because there's planned home births and there's unplanned home births, like baby's coming right now. There's nothing we can do. That's a little bit different. But when we look at planned home births, that study actually showed that there was a decrease in interventions, there was a decrease of maternal mortality, there was a decrease of the high risk complications we see like hemorrhage. There was almost 0% chance of infection because you're in your own space and environment. And so when we have that, when we see those type of studies, it shows that there really isn't the worry that we have is not really present with home births. And when we look at from a global perspective, the countries that have the lowest maternal mortality rate are coincidentally the countries that have the highest home birth rate. We can look at Finland, where somewhere between 30 to 50% of the population, babies are born at home. Switzerland, Denmark. While these are very different demographics, the whole nation is very different than the US. There's other things that we have to look at. When we compare it just number-wise, we aren't seeing home birth specifically being an increased rate of risk. I say that also with the fact that you are going to have outliers of situations. You are going to have emergencies. You are going to have things that kind of come up because the birthing environment can change very fast. So again, it is important that you have that plan. It is important that you know where you're going to do it, where you're going to have the baby. You're within a good proximity of the hospital. You know, if your closest hospital is an hour and a half away, well, sister, I love you, but home birth may not be for you, okay? And so you have to make sure that you are being still safe because there are lives at risk. That's your life, that's the baby's life. So those are all those, when we look at it, we have to weigh all the factors. But generally speaking, home birth is safe.
I'll say two things, and I definitely agree with Dr. Joy, very beautifully put. Of course, we are in the hospital, so we definitely carry that bias with us everywhere we go. With Dr. Johnson actually doing high-risk pregnancies. So yes, in the context of low-risk pregnancies, yes, home births can have very good outcomes. Having said that, two things. Home births do have worse outcomes when it comes to the baby. And so a lot of what we're referencing is maternal outcomes of hemorrhage and intervention, and all of that makes sense. The intervention is going to be less, there's less interventions even possible, and then there's less referencing and checking of things like fevers and things. So there's a particular potential like survey bias as it relates to infection rates and things like that. And that's just kind of analyzing research and just kind of having those, appropriate criticisms of what could be some of the biases there. Another piece is, if we are saying low risk women, and we have determined that Black women are 2 to 3 times more likely to die in childbirth, how do we reconcile that? And so that's one of the things that makes it hard for me. I get that we're talking about low risk women, but if we are just saying, because of what the systems are in place, and if it's all racism and we have, does that negate itself? Does it balance? I don't know. So we have to be very thoughtful. And I think we agree, Joy. I really do think we agree. Yeah.
All right. So I'm gonna jump in here, ladies. I knew that question. That's why I saved it a little later. I knew we were gonna have some good responses to it. So Dr. Chambers, Dr. Johnson, Dr. Joy, appreciate your feedback on that question. I certainly know there are a lot of different factors that come along with it, but I'll tell you what, we got a lot of questions in our comment section. So we're gonna jump in here. This one is from is it Tanisha? I believe it got cut off here, but basically says, I'm 35 years old and I'm scared. What age is considered high risk pregnancy? And does my age play a higher risk in birth defects or genetic disorders? I'll get one person to respond to that because I really want to get through some of these questions.
So 35 in OBGYN is considered advanced maternal age. And that is an arbitrary number that was determined based on the risk of having a baby with a chromosome abnormality. And statistically, your odds are just as high having a complication from something called an amniocentesis, which essentially is an invasive test to check the chromosomes and having a complication versus like having a baby that has Down syndrome. And so this is a very convoluted way that they've determined that the age 35 is considered advanced maternal age. So I say that by saying, I hate the term geriatric pregnancy. I hate that term advanced maternal age. But statistically, there is a higher risk of having a baby with a chromosome abnormality. And so that is why you'll see a lot of literature about genetic testing at that age. All women should be offered genetic testing regardless of their age. But particularly, I think we hone in on that number 35 when we think about a higher risk.
Okay, good stuff. Thank you, Dr. Johnson. What about women with a history of endometriosis? What is the average success rate to conceive?
There's no real average success rate to conceive. What we find is that women who have endometriosis may need additional help with conceiving, and it depends on the degree of endometriosis present. And so if that endometriosis is poorly controlled, they were never treated, they were diagnosed super late, those patients tend to have greater difficulties with infertility. And then those who are diagnosed a lot earlier, who've been on hormonal therapy to kind of slow the progression of the disease, tend to do a little bit better. But there isn't a great statistic that just says, oh, this one's going to get pregnant, this one's not going to get pregnant, because there's so many layers to actual conception and then live birth.
Yeah. All right. Next question here. I don't have who these questions are from, but I'm looking at them, and yeah, let's just get to them. Does breastfeeding prevent you from getting pregnant? What forms of birth control would you recommend postpartum while breastfeeding?
That's good. So lactational amenorrhea is when you're exclusively breastfeeding or primarily exclusively breastfeeding, and that's really good birth control for about 6 months. It's not meant to be used longer than that. It doesn't work very well beyond that time, but before that time, you are exclusively breastfeeding frequently enough, and all of the literature and all the details have to be out. So I would look into that before starting. Yes, that can be a form of birth control. When we talk about some of the options that we want to use while breastfeeding, you really don't want to start birth control too earlier than 6 weeks. There's some school of thought that it can decrease the rate by which your breast milk kind of comes in. And so the estrogen kind of containing medications, we start those a little bit later after you started kind of breastfeeding fully. So after 6 weeks, you really can take anything. Mirena IUDs, those sorts of things can be inserted immediately postpartum and don't have any effect on the birth or the breast milk production.
All right. So I've been wanting to get to this question for a while now. We're talking about drinking wine. Does drinking, okay, wait a minute. So let's start off with drinking wine first and then talk about drinking alcohol and its impact on fertility for women. Not that this is something y'all should be worried about, but y'all asked the question, so I'm gonna go ahead and ask it. Does drinking alcohol impact fertility for women?
So it's not gonna help. Like, drinking alcohol, it doesn't help really anything. Does that make sense? So it's not going to improve your nutrition. It's not going to improve your hydration. It's not going to regulate your cycles. So it's definitely not a helpful factor. Now, when people ask these questions, my point is, how will we find that out, y'all? We gonna make you drink 5 shots and you 0 shots and see who can get like that's there's no ethical way to find it out. And so the idea is that conservatively, no, it's not going to help with pregnancy, but it's not a direct cause to infertility, just ingestion of alcohol. Anything in excess causing cirrhosis or any other major liver damage, yes, that's bad, but it ain't going to help.
It ain't going to help. If you don't remember anything else, it ain't going to help.
And the same goes for once you're pregnant. A lot of women ask me, is it okay to have a glass of wine? I think, the answer is we don't have the randomized control trial to say that women who drank this much and didn't drink this much did better. And so we really don't have a consensus on a safe amount of alcohol for pregnancy. That being said, I feel like if you can abstain from alcohol in pregnancy, great, but a glass of wine is going to be okay every now and then.
The fetal alcohol syndrome is real. So it's just like,
it is. Right.
Yeah. Balance. Okay. Look, really want to give a shout out real quick again to the TheMelaninMD. I mean, they put this panel together and curated this whole thing. So if you're not following them on Instagram, make sure you do so at TheMelaninMD, just like it sounds. And hopefully here soon, they'll have that app created where they can connect all of us to Black healthcare providers across the country. So just wanted to give a shout out to them again for putting this panel here together. A lot of hard work went on behind the scenes, guys, to make this happen. All right, so I actually have a question from a guy. He's on Facebook. His name is Danny. He says, when we speak about maternal and infant mortality, we also have to think about postpartum care and mental health, particularly postpartum depression. Can you touch on PPD and how to speak to your provider about those symptoms and what steps to take once it's recognized?
Well, I think it's important to know that postpartum depression is very common. It affects women who don't have a history of depression. It affects women who may not expect it. And so the first thing I tell patients is that close follow-up with your OB provider in the postpartum period is going to be how we stay on top of things. There is something called baby blues, which is this transient, a few days worth of feelings up and down. But postpartum depression is when you've got that feeling and you can't shake it and it lasts for a month. And so that is a clinical diagnosis. But I think that you don't need to wait 30 days if you're not feeling like yourself. And so making sure, again, that you have a provider that you can trust. And you don't, I think that historically we've said 6 weeks for the postpartum visit, but the College of Obstetricians and Gynecologists are now saying that we need to get in sooner after we have our babies to check in. And so one of those reasons is so that we can stay on top of postpartum depression and any mood symptoms that come up.
All right, Dr. Johnson, can you follow up to this one briefly? What about postpartum psychosis? Is there anything you can do to identify and help get help before something happens?
That's a great question. So I think that women who have a history of depression or any type of illness where they have previously been hospitalized for mood disorders are at a higher risk of postpartum psychosis. However, again, I feel like we shouldn't exclude anyone out of the realm of possibility. And so again, making sure that your support system is checking in on you. And if they feel like something isn't right, they also can speak up and advocate for you with your prenatal care provider. As far as prevention methods, I would say just making sure that you follow up with your postpartum provider so that they can screen you for mood disorders early in the postpartum period.
Thank you, Dr. Johnson. Dr. Chambers, I'm not sure if you want to jump in on this one. Question from Jessica on Facebook. Can we get an explanation on infertility related to fibroids?
So fibroid-related infertility is a little bit more nuanced in the sense of there are women who have full pregnancies who have a ton of fibroids. And so it's not an absolute. It's not remotely an absolute that the presence of fibroids means you won't have a baby. What really impacts your ability to kind of conceive and carry a pregnancy is kind of the location and characteristics of those fibroids, the overall fibroid burden, like the size, because when you're thinking about the real estate in the womb and the uterus, the placenta has to attach to the wall, get adequate blood flow to grow a baby. And so if there are a bunch of fibroids that are kind of limiting the ability for the placenta to attach, there can be issues. Sometimes fertility specialists like REIs will do actual removal of fibroids and then say, go ahead and try to conceive, and women will conceive better after they've had kind of clearance of that uterine cavity. And so it's not an absolute at all, but it certainly can impact a person's ability to conceive or to carry a pregnancy completely to term.
Okay, I got about 3 more questions I want to try to get to. This is from Melissa. She says, I smoke weed for 12 plus years and have quit January of this year. Can prolonged use prevent or have an effect on fertility?
I can't speak to a study that I know, but I know that I don't know, Dr. Chambers, if you have thoughts on this, but I get a lot of questions about, I smoke weed for nausea and pregnancy. Is this safe? And similar to alcohol, there are no studies that have proven that is safe. And we really don't know the neurodevelopmental outcomes that could be long-term for children that are exposed to marijuana use in pregnancy. And so my scientific assumption is that similar to alcohol, you should minimize the use of substances if you're trying to achieve pregnancy, because those aren't things that help increase your odds through healthy living. So
just gonna say, she says she stopped in January, so
no, who knows?
It's been quite a few months. I'm just throwing that out there real quick. Is there an age limit on freezing eggs with Black women?
Not necessarily. Now, the success for egg freezing is going to decrease as you age. And so when you start to look at the likelihood of actually getting any meaningful, mature follicles that can actually go under retrieval, that's going to decrease as we get older. And so some of the thoughts are that preferably getting egg freezing before the age of 35, in the sense of kind of getting those eggs to be below that arbitrary cutoff that Dr. Johnson mentioned for aneuploidies and other abnormalities as it relates to the type of eggs and quality of your eggs that you have. But your body is going to naturally decrease in that fertility because the volume and number and quantity and quality of eggs is going to decrease as you age.
Okay, this is our last question, and then I'm going to allow you guys to wrap us up. Are there specific foods or anything like that can help boost fertility?
Ooh, that's a good one. Okay, so I'll take that as the chiropractor and the natural doctor here. I think when we talk about foods and we're talking about fertility, we want to make sure, again, that we're optimizing health, right? And specifically, let's break down prenatal vitamins. So when we talk about prenatal vitamins and the importance, anybody can take it. And when we do take prenatal vitamins, we want to make sure that we're taking whole food source prenatal vitamins. Those are going to be the vitamins that are actually most bioidentical for your body to be able to retrieve the nutrients that it needs from them. We also want to make sure that we have a good diet, because if we are eating trash, right, our body's not going to be able to understand and recognize nutrients when it sees it. So we want to make sure that we have a good balanced diet. We are overall healthy. And then when it comes to whole food vitamins, we want to make sure that they have folate and not folic acid. We commonly discuss in talking about how women who are pregnant, they need folic acid. What folic acid is? Vitamin B9, and it's a very important vitamin, and it's very essential for the baby's development, right? But folate is actually the whole food source that we get from like green leafy vegetables. And when we have folate, there's so many added benefits of it to create that vitamin B9. Whereas when we're taking folic acid, there's actually some things that we see. So heightened levels of folic acid in the body actually do not help our body to reduce certain inflammatory precursors. Like an example would be homocysteine. And there was actually a study that came out where they studied miscarriages, and they found that 25% of miscarriages have actually excessive levels of homocysteine. So folate conversely actually reduces our levels of homocysteine. So we want to make sure that we're getting in those good green leafy vegetables. We want to make sure that we have a diet that's good in healthy proteins. We want to make sure that we have a diet that is full of your essential vitamins, your omegas, your DHAs, your choline, which come from eggs, and that type of thing.
Okay, Dr. Joy, appreciate that. Okay, so we're going to get some last comments from all of our lovely panelists, our esteemed Black Girl Magic panelists that we have out here. Dr. Chambers, I want to start with you, kind of wrap us up. And one thing I want to say real quick, guys, we had so many questions. We tried to get to as many as we possibly could have gotten to, but you got to remember, this is a conversation that all three of these women can probably talk about for hours and hours and hours on end without missing a beat. So just know that we tried our best to get to as many questions as possible. Dr. Chambers, I want to start with you to wrap us up here tonight.
I just want to say thank you all for tuning in. Thank you to the Melanin MD for even putting this together. These conversations matter. You know, it lets us know that we're not alone. Dr. Johnson let us know that it's not us. You know, we're not victims. It doesn't mean that there's nothing we can do to optimize our health, but we're not the problem. Every single one of us deserves to plan and manage our pregnancies and have as many healthy babies as we want to, hospital, home, wherever, and have the birthing experience and live the lives that we desire. And so my sincerest hope is that these types of conversations help to kind of reinforce that and give us a stronger network of support as, you know, women of color.
Dr. Johnson?
That was wonderful. And I, you know, as an obstetrician, Black women having a safe and healthy birth is the minimum. Like, we deserve more than that. And so I just want women to feel empowered to speak up and to not feel that they have to be with one provider that isn't listening to them, because I think that that has been such a common sentiment when we talk about these tragic things that have happened in the news and, you know, locally. And so just make sure that you advocate for yourself, and there's nothing wrong with you. And you can tell your provider that, hey, like, I deserve to understand what's happening to my body, and that is your right. So please use that power.
Like Dr. Chambers said, we can be that difficult patient and make it happen. All right. Look,
Yes.
Appreciate it. Thank you, Dr. Johnson. Dr. Joy, final words?
Yes. My final words is that birth is beautiful. Black birth is beautiful. Let's celebrate each other. Let's celebrate these growing pregnancies, growing the future generation. You all are beautiful. Thank you for attending. This was wonderful. I loved it. And we need more conversations like this. So let's just move the needle on it.
Yeah, I love it. And speaking of more conversations like this, the Melanin talks that we have been doing here this evening, again, sponsored by the Melanin MD. I mean, I can't thank them enough for putting this on, curating this event. Follow them on Instagram at the Melanin MD. They said the app is going to come soon. Okay. And shout out to Rodney over on Facebook. One of the questions that he had, he said, what can we do to better connect our Black communities with representative care? Hello, that's what this app is going to do, Rodney. Okay, that is exactly what the Melanin MD app will do here soon. One last thing, ladies, we have 1 minute. Folks just wanted to know what cities all of you were in.
Columbus, Georgia for me, joining my father and brother in practice and starting my own practice.
I'm in Chapel Hill, North Carolina.
I'm in Columbia, Maryland.
Okay, and I'm in Dallas, Texas. So if you're in Dallas, watch the news on Channel 8. Okay, appreciate it. Hey, ladies, thank you so much. This has been incredible. I enjoyed this conversation. I learned so much from all three of you, and so much good information. If you missed any parts of it, I've even seen people in the comments saying, sis, they answered that earlier. So you can go back and watch it later. So look, if you missed any part of it, Dr. Joy, Dr. Chambers, and Dr. Johnson, they brought the heat tonight. So again, you guys, appreciate you for joining in such an incredible and needed conversation. Melanin Talks by the Melanin MD, guys. Y'all have a good evening.
Night.
Bye.
Bye, y'all.